Rahman Rahim. Now let's look at the insulin sensitivity, which increase the sensitivity of the peripheral target organ toward the insulin. Okay, so in the beginners, so there are the important drug only is metformin. Okay, which they do what they decrease the insulin resistance. Okay, by improving the insulin ability to move glucose into the cell, especially in the skeletal muscle, and they increasing the sensitivity of insulin. How? Because they are stimulating the GLUT4, okay, which increase the glucose uptake and utilize the glucose via the muscle and the adipose, okay. And they are also decreasing the beta gluconeogenesis. How they decrease? Because they decrease their substrate, decrease the enzyme like PEPCK. What is PEPCK? Phosphoenol pyruvate carboxygenase, which is very important enzyme in the gluconeogenesis, okay, which convert the oxaloacetate into the PEP. They impair the glucose absorption from the GAT, improve the lipid profile. So one of the other beneficial point is they are improving the lipid profile. How? Because they decrease the LDL and decrease the VLDL and increase the HDL. So there are two beneficial points. On the one hand, they are improving the lipid profile. On the other hand, they are improving your glucose level. Okay. So pharmacokinetics, oral administration, not bound to serum protein, you can say the volume of distribution will be higher and not metabolized, excreted unchanged in the urine. Okay, there is no almost no metabolism, you can say. So excreted in unchanged form. And their half-life is 3 hours, so a patient should use it 3 times a day. Okay, in the clinical usage, so obese patients with diabetes type 2, this is first line therapy because they improving the blood glucose level as well as decreasing the body weight. Okay, so they decrease the blood glucose and decrease the. So our first, whenever someone is diagnosed with diabetes, so our first line therapy is the metformin. Okay, so then you go for the based on the condition, so you go for the combination or the change of the drug. So diabetes mellitus as a monotherapy or in combination you can use it because decreasing the blood glucose. Nowadays, they are also approved for the pre-diabetic condition as well as the gestational diabetic. So this is latest ADA update. Okay. And the other important use is the polycystic ovarian syndrome. Because why? Because they decrease the insulin resistance as well as they increase the ovulation. So that's why it can be used in the polycystic ovarian syndrome. Okay. So there are a lot of beneficial points associated with the metformin. In nutshell, they are decreasing the fasting plasma glucose, they are decreasing the HbA1c, they are decreasing the LDL and VLDL and increasing the HDL. So these are some beneficial points associated with the metformin. Okay. So some adverse effect, one is the GAT disturbance, most common, that is because they are metallic taste in the mouth and causing nausea, vomiting, diarrhea. But it's in the early dosing. If the patient take for a few weeks, this side effect will be subside. Okay. And to avoid the intestinal side effect, the patient should take it with the meal or start at the low dose, then they can increase the dose. Okay. And one of the rare side effect, but life-threatening side effect, that is the lactic acidosis. Although there are, you can say, rare cases in the hospital, but this question is repeated again and again in the post-graduation exam, especially the USMLE or you can say FCPS or any the PG exam. Okay. Their mechanisms are not clear, but if it's considered if there is a renal insufficiency or liver disease or alcoholic heart failure, hypoxia, so there is a higher risk of the lactic acidosis. Because if the renal insufficiency, no excretion for the lactic acid, liver disease, no metabolism for the lactic acid, and if it's alcoholic, they increasing the lactic acid. When there is where the lactic acid come from? Anaerobic glycolysis. Okay, so alcoholic patient increase the lactic acid production. If there is heart failure, hypoxia, that means they also stimulate the anaerobic glycolysis because there is heart failure, hypoxia, means there is low oxygen supply towards the tissue. Okay, and one other side effect, that is megaloblastic anemia after the long-term usage. So why? Because they interfere with folate and the vitamin B12 absorption. So if this side effect come, so you can manage it by giving the folate and a B12 supplement. So overall, if you can see, there is this side effect can be managed, so this can be managed, so lactic acid is there. So there are a lot of beneficial points associated with the metformin use. Okay, contraindication if the renal disease because they cannot excrete the lactic acid, liver disease cannot metabolize the lactic acid, alcoholism so because this increase the lactic acid, cardiopulmonary dysfunction mean they decrease the oxygen delivery tissue which increase the glycolysis which can increase the lactic acid production. Okay, so their advantages. One important advantage they cause the weight reduction without hypoglycemia. So you can say sulfonate urea was the hypoglycemic diet. So this is euglycemic. Okay, so sensitized as the euglycemic, and they improve the as well as the lipid profile which is responsible for the weight reduction, and also it's inexpensive. Now let's look at the thiazolidine. So where you have glitazone, pioglitazone, and rosiglitazone. Okay, so they are associated with the activation of PPAR gamma. What is PPAR gamma? Peroxisome proliferator activated receptor gamma. So there is PPAR alpha and PPAR gamma. PPAR alpha is important in the dyslipidemia condition because the fibrates activate the PPAR alpha which increase the lipolysis. Okay, so that's beneficial in the treatment of the dyslipidemia condition, or you can say hyperlipidemia. While the PPAR gamma activation is important way in the you can say anti-diabetic condition. Because this is the PPAR alpha or gamma, they are mainly associated with the fat metabolism, but you can say PPAR gamma can because they have some transcription genes which involve in the glucose and the fatty acid metabolism. So let's see their beneficial their effect of the PPAR gamma. So they increase the fatty acid uptake by the fat cells. So in this way they are responsible for the proliferation of adipocyte, mean adipogenesis you can say. So as they increase the adipocyte, they increase the adiponectin release, which is responsible for the insulin sensitivity. So they increase the insulin sensitivity. So because you can say one of the secretory protein coming from the adipocyte is the adiponectin, which actually increase the insulin sensitivity, and they antagonize the tissue necrotic factor alpha, which is tissue necrotic alpha actually do what they is responsible for the insulin resistance. As you antagonize this, so you can decrease the you can say alpha insulin resistance. Okay, so this is one of the action of PPAR gamma, and other they are responsible for the upregulation of GLUT4, so which will increase the glucose uptake and utilization in the muscle and the adipose. Okay, and they are also decrease the hepatic gluconeogenesis. So in this way you can consider they are increasing the insulin action, most of the insulin action. Okay, and pharmacokinetics, they are orally only once daily dose, and they highly bound to plasma protein 99%, so low volume of distribution, and slow onset of activity, and the metabolism in the liver and excreted in the urine as well as in the bile. So if there are renal disease patient, so the excretion can occur via the bile pathway. Okay, and their half-life is 3 to 4 hours. In the clinical usage, type 2 diabetes mellitus with insulin resistance as a monotherapy, or in combination with the sulfonate, urea, biguanide, or insulin, depending upon the advanced condition. So because they decrease the blood glucose. So advantages can be used in the renal insufficiency and no hypoglycemia as alone. If someone is using sulfonate, urea, the insulin, so they can cause the hypoglycemia, but it alone cannot cause the hypoglycemia. In nutshell, they are decreasing the fasting plasma glucose, decrease HbA1c, increasing the HDL somehow. Okay. So adverse effect, hepatotoxicity, one of the important side effects. Recommendation, so monitor the LFT liver function test for the first year of the therapy. So and they cause the failure of the estrogen containing oral contraceptive. The lady which is taking oral contraceptive containing the estrogen, so there will be ineffective. Okay, they cause the weight gain. How they cause weight gain? Because the PPAR gamma actually causes proliferation of the adipocyte, which increase the weight. Okay, so they cause the edema in the 5% you can say patient, but this is also contributing the weight gain. Okay, but so as the PPAR gamma actually increase the sodium retention in the nephron, so which is responsible for the edema. So they increase the fluid retention, which causes the edema. So so you should be consider it in the cardiac patient, because as their edema means there will be increase the level of fluid. So this fluid can enter back to your cardiac. So this will increase the you can say workload of your heart and your lungs. So that's why it's contraindicated in the cardiac patient. Okay, so avoid in the cardiac patient. And they can cause the congestion, heart failure, and there is increased risk of bladder cancer with the pioglitazone, and they increase the risk of the internal MI with the rosiglitazone. So these are special side effects with the drug. Okay, and the troglycerin, which I not mentioned because it's removed from market. Because very important side effect is this, they cause the hepatotoxicity or you can say liver failure eventually. So that's why this is not in use nowadays. Okay, this is older drug. Amylin analog. So these are amylin analog, which is a pramlintide. This is what this is actually amylin is what? Amylin is a pancreatic hormone which is released with the insulin. They actually increase the effect of the insulin. How they increase the effect of insulin? Because they decrease the glucagon. So in this way they decrease their competitors, so which increase the insulin action. Okay, and they also decrease the appetite and they delay the gastric emptying. So in this way they are useful to maintain the blood glucose. Okay, pharmacokinetic given subcutaneously with insulin. They are not used as alone, so always used with the insulin. Okay, so clinical usage, diabetic type 2 or type 1. Okay, because they are used with the insulin, so this can be effective. So insulin, because they increase the action of the insulin, so they decrease the blood glucose. And the adverse effect, one of the very important is the hypoglycemia, and the other is nausea. Hypoglycemia can be managed if there is hypoglycemia. You should decrease the insulin dose, so there will be no effect, adverse effect of the hypoglycemia. In the nutshell, they are decreasing the postprandial glucose and decreasing the HbA1c. So here you can manage it by decreasing the insulin dose. Now let's look at the alpha glucosidase inhibitor. They decrease the carbohydrate digestion, so they decrease the glucose absorption in the small intestine. Okay, so acrabose or maglitol or the wegovy, so these are drugs. Okay, so they actually reversibly inhibit the intestinal alpha glucosidase, which decrease the carbohydrate digestion, decreasing carbohydrate digestion, decreasing glucose absorption, decreasing the blood glucose. So they lower the postprandial glucose level as well as the HbA1c. Okay, acrabose, especially pharmacokinetic, they are given orally, not absorbed, poor absorption you can say, and they are excreted in the feces as well as in the urine, taken just before the meal. Okay, so in clinical use, if there is impaired glucose intolerance, so especially in the pre-diabetic patient, this is useful. And the type 2 diabetes in the combination with other, not as alone, because they are just decreasing the upcoming glucose. Okay, so never use alone to treat the severe hypoglycemia. And it can be used for the treatment of type 1 because they are decreasing they are not affecting the pancreatic beta cell, so they are just interrupting the absorption of the glucose. Okay, advantage no hypoglycemia as alone, and they are considered as insulin sparing because they decrease the insulin usage, because less glucose is coming into the blood, so less insulin will be used. So in this way, their other name is insulin sparing drug. Adverse effect in the GIT disturbance because they increasing the glucose level in the gut. There will be overgrowth of the microbes, so which are responsible for the flatulence, diarrhea, and the abdominal pain and the bloating. Okay, so the magnitude especially contraindication because if there is a irritable bowel syndrome or inflammatory bowel disorder and it's intestinal obstruction, because they are increasing the glucose level in the intestine, so this worsens the condition. Okay. So in the nutshell, they are decreasing the postprandial glucose, they are decreasing the fasting plasma glucose, they are decreasing the HbA1c. So SELT2 inhibitors, so they increase the glucose excretion via the urine. So gliflozin, dapagliflozin, canagliflozin, empagliflozin. So here is just look at the nephron. So here is your glomerulus, here is the proximal tubule. Okay. So you can see SELT1 and the SELT2. Okay, sodium glucose co-transporter here. So if there is excess glucose, so this enter into glomerulus and filter into the proximal tubule, where they reabsorb via the SELT2 and SELT1. Okay. So 10% of glucose reabsorption occur via the SELT1 and 90% of glucose reabsorption occur via the SELT2. Okay, so this is condition without the SELT2 inhibitor. If you inhibit the SELT2, what will happen? So no SELT2 action means what will happen? Some glucose reabsorbed via the SELT2, but some glucose will be excreted via the urine. Okay, as well as sodium. So sodium and glucose urinary excretion by using the SELT2 inhibitor. Okay, so in the mechanism of action, they inhibit the SELT2, so inhibit the glucose and the sodium reabsorption, so they increase the excretion of the glucose. In this way, they decrease the blood sugar. So they by decreasing the glucose, so they decrease the blood sugar. By increasing the excretion of your sodium, they also have the osmotic diuresis effect. Okay. And the clinical uses type 2 diabetes with exercise and diet to control high blood sugar because they increase the excretion of the glucose. And if there is established cardiovascular disease and the diabetes, because excretion of glucose, decrease the blood glucose, and excretion of sodium, decrease the cardiac events. Okay, so they decrease the risk of the major cardiovascular events. And they, in the adverse effect, may cause hypoglycemia, okay, urinary tract infection because of you are inhibiting the SGLT2, so UTI, yeast infection, especially you can say the candidiasis in the vagina or penis, itching in the vagina or penis, or polyuria. Why? Because of osmotic diuresis, more and more sodium go out, more and more water also go out. Okay, so dry mouth, thirst, and fatigue. So these are adverse effects. But there are some severe adverse effects like the diabetic ketoacidosis, because when there is too much glucose level low, so this causes diabetic ketoacidosis, and pyelonephritis are the sepsis. So these are very, very serious side effects. Okay, so in the nutshell, they are decreasing the postprandial glucose, decreasing the fasting plasma glucose, decreasing the HbA1c. Okay, although we have covered all the mechanisms, so let's look at the drug of choice condition. So actually, when you diagnose, so you start with the diet and exercise when if the HbA1c is more than the 7%. Okay, if not managed, so then you go for the oral monotherapy. Which drug? Of course, start with the metformin. So then, if it's still uncontrolled, so you go for the oral combination therapy. Especially you avoid the 2-secretagogue, okay, the sulfonylurea and magnesium, because they can cause the hypoglycemia. Okay, but you can use the insulin sensitizer with the sulfonylurea. Okay, so HbA1c, if it's still more than the 7%, so you can use the oral drug with the insulin. If it's still ineffective, so then you can go for the insulin because it's the advanced stage. Okay, so here are some conditions where you should choose the drug: obese, non-obese, elderly, and the Asian. So monotherapy, first combination, secondary. In the obese patient, which drug you should use? Metformin. Avoid the sulfonylurea because they cause the obesity. Okay, and then you go for the first combination with the sulfonylurea and exenatide, or then second combination you can use the insulin or exenatide glitazone. Okay, sulfonylurea will be no problem because the metformin decrease the weight. Okay, so this can be balanced. So non-obese, so you can use sulfonylurea or metformin. So if you are using the sulfonylurea in the advanced stage, you go for the metformin, and if you are already using metformin, then you add the sulfonylurea. Okay, in the second combination, you can use any of these drugs. In the elder patient, in the old age, so secretagogue start with a low dose because they have a renal problem. So if it's you can say ineffective, then simply switch to the insulin. Okay. In the Asian, we start with the glitazone, then go for the metformin combination, or then go for the sulfonylurea or the insulin combination. So exenatide combination with the glitazone is most of the time avoided. So renal failure, you should avoid the metformin or and the long-acting sulfonylurea. And in the severe heart failure, avoid the metformin as well as the glitazones. Okay, so because they cause the edema which increase the heart failure effect. And gestational, avoid most of the oral antidiabetic except the metformin that can be used. And in the cardiovascular disorder patient, you go for the gliflozin and the GLP-1 mimetics. And in the hospitalized patient, which is critical condition, or when the your HbA1c is more than 9.5, so then you go for the simply insulin. And in the gestational, use the insulin or the metformin. So combination, there are some fixed combination pills come in the market like glimepiride and metformin. So these are some beneficial effect of this combination. They increase the insulin secretion as well as decrease the resistance. Okay, so other beneficial products are here, so you can read it. And the vildagliptin and metformin, which is most common combination. The vildagliptin is what? CP4 inhibitor, metformin is the sensitizer, so they increase the secretion, they decrease the resistance. Okay, so in this way there are a lot of beneficial point for this combination still. And other is glipizide and metformin, similar useful effect. And the other combination, rosiglitazone and the metformin, both are sensitizer, so they increase the sensitivity, improve the glycemic control. But very important, their advantage is they improve the beta cell functioning. Okay, so there will be improvement in the pancreatic beta cell functioning. So some oral antidiabetic with the non-diabetic condition like hypertension or any hyperlipidemia. So Can you use the beta blocker? Because heart patient, the hypertension patient most of the time use the beta blocker, so they are contraindicated with the diabetic. Why? Because one of the there are two problems major with the beta blocker. Number one, because when there is a hypoglycemia, what is the alertness? Energetic alertness. There is tachycardia, palpitation. Okay, normally patient don't feel the heart is pumping, but when there is tachycardia, you feel the heart is pumping. So in this way, when someone is taking beta blocker, there will be no tachycardia. So that's why patient without alertness going to coma, because if it's hypoglycemic, he can take some meal to adjust their glucose level. If there is no alertness, he can go to coma and maybe he can go to death. Okay. The other the problem is when there is hypoglycemia, normally there will be increase the glucose release from liver. Beta blocker also decrease the glucose release from the liver. So in this way, these two major problem is the beta blocker. So that's why this combination is contraindicated. Okay, decrease the glucose release from liver and decrease the adrenal mediated symptom of the hypoglycemia like palpitation. So and patient may die without the alertness of the hypoglycemia. So this is contraindicated combination. And the other, if someone is taking the thiazide diuretic and a glucocorticoid, so which are causing the hyperglycemia. So in this condition, you should manage by increasing the drug dose. Okay. So only insulin usage condition when there are advanced conditions, especially when the history of ketoacidosis. Okay, ketoacidosis tell you the mean your most of the pancreatic beta cell are the non-functional. Serious infection because of a high glucocorticoid, stress condition, surgery condition, stress condition, concurrent illness like acute pancreatitis, increased glucocorticoid, pregnancy to prevent from the fetal hypoglycemia. So in this way, you should always use the insulin. There are some relative indications you can consider it when their blood glucose crosses the 300, and if there is failure to achieve the target with the 2 or 3 oral agents, or if there is weight loss condition or the someone is taking the high dose steroid, so you can use the insulin. Okay. So here are the summary tables. Where you can read it on your own self. So all the points are summarized in this one picture. Okay. Thank you very much. Allah Hafiz.